So good morning, everyone. Greetings from London. So we have here in a very a good day. On Wednesday, 15th of November, we have Dr. Ayako Kohno from the School of Public Health, Graduate School of Medicine from Kyoto University of Japan. So today, Dr. Ayako will share about theories and topics on healthcare access in Japan. So Dr. Ayako also will share about the case study about the healthcare access for minority group in Japan, which is a study that we conducted jointly on 2020, I think.
Yes.
Yeah, under the Toyota Foundation grant. So it's a pleasure to have you here, Dr. Ayako, and for all students, please listen and then learn as many as possible. Okay, thank you so much. I handed all the event to you, Dr. Ayako, and to Aurel as well. Thank you so much. So I'm sorry, maybe I could not join for the whole session.
No problem. Thank you very much for.
Yeah.
Okay. Thank you for the nice introduction. So very happy and honored to talk to you today on the theories and topics on healthcare access in Japan. As Dr. Inge kindly introduced me, I am currently an assistant professor in the School of Public Health in Kyoto University. So in today's lecture, I would like to introduce to you about the following topics, as you can see in this slide, for about 1 hour. And then after that, please ask questions for about 30 minutes for discussion time. So first, I want to make some comparison of Japanese and Indonesian healthcare system, and followed by the going back to the definition of healthcare access. And in align with that, I want to introduce a concept called system thinking. And after that, some theories related to healthcare access and some topics of healthcare access in Japan. As Dr. Inge introduced to you all, we have done some studies on the minorities in Japan who are the Muslim who live in Japan, how to access healthcare while they are living in Japan. So that might be an interesting topic for you. And lastly, to summarize what I have lectured so far. Okay, sorry. And this map shows the Asian region. And as you can see, Indonesia on the green color. And I am in Japan now on the green, orange color. I live in Kyoto, and you all are in Surabaya. And there are some distance, 4,819 kilometers, but thanks to the technology like Zoom, and also connected to Dr. Inge in London, we are able to share our experience real time in different parts of the globe. And this is a picture of Kyoto now. We are in the autumn season. This is a temple picture of the Kiyomizu Temple, one of the famous sightseeing place in Kyoto. I don't know, some of you have come to Kyoto before, but we are known as a very beautiful and have many sightseeing and historical places. So I invite you to come to Kyoto, especially in autumn or April season, if you have some time. And also, I would like to introduce briefly about our school, Kyoto University School of Public Health. We are established in 2000, and you might think it's a very early, new, but still oldest and largest School of Public Health in Japan. And there are 18 departments and courses within Kyoto University School of Public Health, so you can learn all different kinds of subjects like healthcare economics or statistics or epidemiology and all other types of public health issues. And we offer MPH, Dr. PH, and PhD in medicine degrees. So any of you interested in learning in Japan for your near future for master or PhD, please consider Kyoto University as one of your options. And if you want to know more about in detail, there's a website, so please have a look. And now I want to make some comparisons. So I made some figures in the table. So I want to look at it one by one. So first of all, the population in Japan, we have about 123 million people, whereas you in Indonesia, you have 277 million people. So the Indonesian population is more than double of Japan. And in terms of land area, Japan is 378,000 kilometers, but Indonesia 1.9 million kilometers. So maybe I go back to the map again. This green area is 5 times larger compared to Japan. So Indonesia is a very big country, and you have many land area. And also mean age of population. Japan is an aging society, so the average age is 41.4 years compared to Indonesia, 29 years old. So Indonesia is a quite a young population, we can say. And also aging rate is 29% in Japan, but in Indonesia also only 6.8%. So in terms of the aging rate also, you are a very young population. And average life expectancy for male is 81.05 in Japan and 87.09 for female. So we are in Japan living very long, but compared to Indonesia, 60.67 for male and 73.55 for female. So as you can see, between Japan and Indonesia, the average age life expectancies is at almost more than 20 years for male and about 14 years for female. So how you can see that depending on where you live, the life expectancy may vary. And so overall, as you can see, all the numbers shows that Japan is very many elderly and living long. And compared to that, Indonesia is still young, but the life expectancy is still relatively lower compared to Japan. But the last part I would like your attention, because the absolute number of elderly who are those who are above 65 years old, we have 35 million in almost 36 million in Japan. But in Indonesia, it's very notable that you already have, as of now, 18 or almost 19 million elderly, those who are above 65 years. This is because your population is quite large, that in terms of absolute numbers, you have the number of Indonesian elderly is about half of Japan. I think this is very important to know because in Japan now, because we have so many elderly, there are so many issues and also, policies and programs in place that are supporting the elderly to live long and receive healthcare. So in line of thinking, Indonesia also need to put a lot of efforts to support elderly because you currently already have many elderly in absolute numbers. And this another slide shows the healthcare system of Japan and Indonesia as a comparison. And I also want to highlight you to some statistics. And first, medical expense as a percentage of GDP. Japan spends about 8% of our total GDP to medical expense, whereas in Indonesia, as I checked, it's about 2.9%. So in terms of this comparison, I think Indonesia has some still way to go to increase the number of medical expense as percentage of GDP. And also physicians per 1,000 people, Japan is 2.67, but in Indonesia, only 0.63. So in terms of that also, I think Indonesia also need to pay more attention and put a lot of efforts to bring more physicians to the society. And also number of hospitals in Japan, we have 8,300. So compared to that, in Indonesia, you have 2,985. So even though Indonesia has more population, I think you need to have more number of hospitals. So this is another challenge issues faced by Indonesia now. And also the number of public health centers. This is very interesting, I think, and I will elaborate more in the next slide. But in Japan, we have what we call Hokenjo, which is Japanese in Japanese language, means public health centers. But we only have 469. Compared to that, in Indonesia, you have Puskesmas, which is 10,205. I think this is a very original and unique situation for Indonesian healthcare system and something you should be proud of. I think that in most of the communities everywhere in Indonesia, you have access to public health centers. And that's a very advantage and good point about the Indonesian healthcare system. And lastly, number of clinics in Japan, we have 102 and 102,000. But in Indonesia, you have 11,347 clinics. So please note for now the difference, how the situation is quite different in Japan and Indonesia, and why the reason I will explain more in detail in the next slide. So this next slide shows the types of healthcare facilities in Japan. As I explained to you in the previous slide, that the number of number of hospitals in Japan is 8,300. But this is only 7.5% of the total number of medical institutions in Japan. So all the rest is clinics. That is some 102,000 that constitute 92.5%. So this, I think, is similar in all countries, but especially in Japan, the percentage of hospital, tertiary hospital is very small, and we have many, many clinics. And even within the hospitals, you can see that the public ones are only 9%, and all the rest are 71% are private. So most of the hospitals in Japan are predominantly private. And same goes to clinics. Public clinics are only 4%, and all the rest, 83%, are private. So as you can see, Japanese healthcare institutions are predominantly private. And also, I want to explain to you about the healthcare centers in Japan. As I explained to you in the slides before, we have 469 public health centers called Hokenjo in Japan. And what are the functions of all these public health centers? They do various things, such as collecting demographic statistics on health-related matters, and also medical and pharmaceutical consultation, but not the diagnosis. But if you want to ask about your medication, you can ask public health centers. And also preventive measures against infectious disease, such as tuberculosis and new influenza. In time of COVID-19 infection spread, the public health center played a major role in collecting information about how many people are infected. Also, countermeasures against AIDS and intractable disease. They provide information and also conduct testing. And also matters concerning mental health and welfare. So in public health centers, they provide information to people who have schizophrenia, depression, and also other mental health consultations, such as mental illness, hikikomori. That's originally a word by Japan, but I think now this word is known globally, that someone who has difficulty going out to the society and spend most of the day in their own room, even isolated from their families and not being able to work. This is called hikikomori, but also alcoholism. So all these people, they can receive support available over the phone or at the counter if they go to public health centers. And another function of public health centers refer to related organizations such as medical institutions, depending on the content of the consultation. And lastly, life hygiene related matters, food hygiene, testing for food poisoning, and environmental hygiene, water quality surveys. So you can see that in Japan, public health centers covers all these diversified many tasks to improve the situation of the community. And lastly, business license for food-related facilities, chef licenses. So in Japan, if you want to open a restaurant, you need to get approval from the public health centers for their hygiene, for food safety, and so forth. Next, I would like to introduce the types of health insurance in Japan. Japan is known as having universal health coverage, and all citizens and even foreign residents living in Japan are covered, subscribing to at least one of the following health insurance system. The main one is called NHI. It's a national health insurance. So who is enrolled? It's those who are self-employed, freelance, or students. And the number of subscribers are 31 million people. And there's another type called EI, employee insurance. So who is enrolled in this is employees of private companies and also public servants. So the numbers of subscribers are 77 million people. And we have another third type called MCSE. This is a medical care system for the elderly. So if who is enrolled, if you are become above 75 years old, you will be automatically removed from this NHI or EI and transferred to MCSE, which is an insurance system for the elderly. And currently we have 18 million people who are under MCSE. And this slide shows the healthcare cost under insurance scheme. So as I explained to you in the previous slide, all people who live in Japan need to be subscribing to at least one type of healthcare insurance. So you need to pay a monthly premium fee, which varies depending on your income level and so forth. But in addition to that, if you actually go to the clinics or hospitals, you need to pay for the cost of healthcare. And the cost is different, and I want to explain using this picture. Since you are born until 6 years old, your medical cost is 20% of the actual healthcare cost. And if you are above 6 years and between 70 years old, you need to pay 30%. So the rate increases. And above 70, you are reduced to 20% again. But if you are in a so-called high income group, which you're still working or have some revenues and you can afford, then your healthcare cost remains still 30%. And at last, if you become above 75 years old, the actual healthcare cost reduced to 10%. So this is how the actual cost may vary depending on how old you are. And this next slide, I want to explain about the burden structure of Japan's national medical expense by finance sources. In 2019, the available statistics is a bit old, but still about the balance is about the same for this year too. So please note that 28% is covered by monthly premium of the medical insurance fee. So as I explained in my earlier slide, everybody pays medical monthly premium fee. So 28% of the medical expense is covered by this premium fee. And another 21% paid by the employer of the employee insurance. So companies help a lot to support the burden of medical expense in Japan. And another 25% central government funding, another 13% local government funding, and only 12% is those costs incurred by patients. So as I explained in the previous slide, you need to pay only 10 to 30% of the actual cost. The payment is covered, covering 12% of the actual total medical expense in Japan. I don't know if you see this as a good way to support medical insurance fee. In some of the countries, I'm not so sure about Indonesia, but central government funding constitutes most of the medical expense. But in Japan, it's only 5%, and all the rest is covered by different sources. So I want to summarize what I have explained so far, the main characteristics about healthcare in Japan. All citizens are covered by public medical insurance of any kind. And if a person has an insurance card, one can freely receive medical care using health insurance at any medical institution at any time. This is so-called free access to healthcare. So unlike other countries like UK that I know that if you want to receive healthcare at the low cost, you need to go to the GP, general physician, at the place of your living. But in Japan, it's not the case. So you don't necessarily have to go to one clinic nearest to where you live, but you can go to a faraway place if you think that the quality of the healthcare is better. And either way, you go to public or private hospitals or clinics, basically the medical cost is not that different. And another characteristic about Japanese healthcare is that advanced medical care is provided at a low medical cost. And finally, public funds are invested in healthcare, but not all. Okay, so that was a quick overview and comparison of Japan and Indonesia in terms of the total country situation and also healthcare system. And now I want to move on to the definition of healthcare access. I'm sure you have learned this already, but I want to revisit the definition so that we have a common understanding. According to Institution of Medicine definition in 1993, healthcare access is defined as the timely use of personal health services to achieve the best health outcomes. So this is very simple definition of healthcare access. And in my personal view, I want to elaborate this definition, interpreting the nuance of what it means to have a good healthcare access. And in my point of view, there are two elements. One is that anyone can access to healthcare services without delay when you need them, and it leads to better health outcomes. So this corresponds to the timely use in the definition of IOM. But even though the healthcare is there, if you don't need it, it's not so much relevant to you. But when you are in need, you'll be able to receive healthcare. That's a very important aspect. And another element I want to highlight is that healthcare needs of an individual is fulfilled by accessing the type of healthcare that would satisfy their need, desire, expectations, needs, or demands. So you can see that the healthcare access is not only the availability of the healthcare, but you have some needs or expectations. And when this kind of expectation is fulfilled, then you feel that your needs is satisfied. So I think this is a very important aspect. And now I want all of you to think about healthcare access from whose point of view. So, of course, patients and also family and carers of the patients, but also from the healthcare providers' point of view, how to efficiently provide healthcare. And also the government and businesses, because they are the funder of the healthcare access. So I just want to highlight in this slide that when we speak about healthcare access, it can be looked at from various types of people's point of view. And there are diverse issues to be solved, improved, and reformed, depending on whose point of view. To solve or enhance understanding, I would like to introduce this idea called system thinking. I don't know if some of you have learned or heard about it before, but system thinking is a holistic approach to analyze that focuses on the way that a system's constituent parts interrelate and how systems work over time and within the context of larger system. So when we speak about healthcare and healthcare access, it's very complicated and many people are involved and you have to deal with many different components. So having a system thinking mind will help you to solve and enhance understanding. So system thinking consists of three things. That first of all, you have some elements. In this case, characteristics of what you want to study or enhance understanding. And the second part is interconnections. So the way these characteristics relate to and or feedback into each other. This is an important thing you need to understand. And lastly, a function or a purpose. So whatever you want to improve or change, you need to clarify. And application of system thinking in healthcare, how is it? There are many publications, but I found this one publication interesting and you might want to read it further if you are interested. The title is called The Application of System Thinking in Health, Why Use System Thinking. And because a lack of time, I won't be able to explain the whole contents, but I just want to give you the main message highlighted in this paper. I write it down here. So the application of system thinking in solving problems in the field of healthcare will allow our mental model to be visible in such a way to demonstrate how various things fit together. So system thinking is a tool you can use to visualize context and also share with different people involved in improving healthcare access. So in this paper, this concept is introduced. It's called causal loop diagram. Abbreviation is CLD. What the causal loop diagram looks like is you can see on the right-hand side. It's basically consists of some words, keywords, and also arrows. So how to create this CLD? There are 4 steps I want to briefly explain. The first step is create variable names. So whatever you are interested in, you create a list of things that you want to study further. So for in this example, health worker inventive payment, health worker motivation, number of patients treated, stock of drugs, ability of health workers to provide services. So in this case, they are dealing with hospital management or health medical care provision. So all these elements you firstly list up. And step 2 is draw the links. So as you can see in this figure, you try to connect different elements by drawing the lines or arrows. And step 3 is label the loop. So according to this type of causal loop diagram, there are only 2 types. It's called reinforcing or balancing. So whatever you found out that interrelationship between each element, it can classify as either reinforcing or balancing. So depending on the context, you try to label one of these. And the last step is talk through the loop. So this is a very important part, not only drawing and finish, but also you need to tell the story to be sure the loops capture the behavior being described. So this is a simple, basic explanation of what causal loop diagrams. I think you can apply this concept in any of the topics or project that you are interested in. If you want to learn further, there is a YouTube video explaining and also a web page. So please refer. And if you become advanced in drawing the CLD, you'll be able to show graphically the complex system. In this case, they are trying to show the healthcare management system in macro scale. So in the center, they have effectiveness of health system. And related to that, you have like fragmentation of health services, workforce dropouts, finances, governance structures, levels of leadership, and human resource management, and availability of health services. So all these different components, it might seem like independently and not associated different issues, but when you try to think about it in totality, they are interrelated. So I think CLD is a useful tool to be able to show all this interrelationship visually. And also in this slide, I want to explain to you the elements of healthcare access. There are generally 4 types of healthcare access elements. One is coverage, so facilitates entry into healthcare system, and uninsured people are less likely to receive medical care and more likely to have poor health status. So when we talk about healthcare access, who is can have easier access, who has more difficult access coverage, we need to think about it. And the next element is services. So having a usual source of care is associated with the adults receiving recommended screening and preventive services. So the type of services, when we talk about healthcare access, what are available and what are difficult to be accessed, we also need to have a better understanding. And the third factor is timeliness, its ability to provide healthcare when the need is recognized. And lastly, workforce. So it's important that when we talk about healthcare access, to make sure there is a reliable workforce that can provide capable, qualified, and culturally competent healthcare providers. Next, I want to also explain to you the theories related to healthcare access. And the theory is called the Social Ecological Model of Health, SEM. I think some of you have studied about this already, but I want to explain briefly. This model conceptualizes health broadly and focuses on multiple factors that might affect health. So as you can see in the figure here, SEM is drawn by 4 different layers: individual, relationship, community, and society. So SEM assumes that health is affected by the interaction between individual, the group, relationship, and community, and the physical, social, and political environments. So I just want to give you an example of factors affecting health at the individual level. There are so many factors, and this is not, of course, the exhaustive list, so there might be some others, but I just want to highlight the simple, basic ones. Personal characteristics such as age, education, income, and health history influences how the one person is healthy or unhealthy, and also adherence. So the patient agrees with the decision on the treatment policy and actively receive treatment. Whether a patient is adhered into the healthcare provider's advice or not certainly affects people's health. And also communication skills. The patient can communicate effectively with the healthcare providers or not. This also has some influence on the consequences of health of the individual. And also health literacy. The patient can understand health-related information or not, and living environment. The patient can live without difficulties, harm. For example, if you have broken leg, but your living arrangement is such that you need to use stairs and there's no elevators or escalators, then it must be difficult for you to spend daily life. And lastly, financial resources. The patient can pay for healthcare. This is an important factor affecting your health status. Next, I want to explain the examples of factors affecting health at the relationship level. So there are so many factors also, but just highlighting two examples. The relationship with your friends, partners, and family members influence the health of an individual. So this is less obvious comparing to the factors influencing at the individual level, as I explained to you in the previous slide, but it's very notable that who you interact with, your friends, families, certainly have some influence on how healthy or unhealthy you are. And as an example, it would influence the health of a person in a positive way by creating walking clubs and work with community groups to introduce healthy menus and cooking methods. Also to promote community gardening groups and other social gathering activities in the community, and it would help you to become more healthier. Next, I want to give examples of factors affecting health at the community level. So the characteristic of settings and living environment in the society that affect health of an individual. Example is work with the local grocery stores and convenience stores to help them increase the amount of fresh fruits or vegetables they carry. So this is something, arrangements that is difficult to be done at the individual level or even interpersonal level, but if there is one grocery store in the community who will provide catering service to delivery service to your home, then you don't have to carry heavy vegetables back to your home. An established farmers market that accepts food stamps so that low-income residents can shop there. This is another system introduced locally that will help low-income people to have more secure way of accessing to healthy food. Lastly, work with the city or county to identify walking trails, parks, and indoor sites where people can go to walk. So all these things, if you plan carefully and coordinate some activity programs, then not only one individual, but everyone in the community may benefit and become healthier. And lastly, example of factors affecting health at the society levels. So this, again, there are many, many examples, but I just want like to highlight one so that you have a more clear image. Social norm may affect people's health. So example is that an elderly may think that he or she is not properly taken care by his or her adult children if elderly is living alone. This may lead to a feeling of loneliness and depression among the elderly who live alone. So I heard that in Indonesia, there is still a common social norm that elderly, if they live alone, they might be considered as not properly taken care by your adult children. But in Japan nowadays, some people might still think that way, but majority of them don't think that way. And some of the elderlies are happy to live in alone and independent from your adult children. But all this kind of social norm, if it exists, then depending on where you live, which country, which cultural background you live in, some people might automatically feel that you are not well taken care of and feeling lonely and depressed. So that as a society affects health of an individual. Okay, so that was the explanation about the social ecological model. And now I want to move on to introducing some of the issues addressed in the annual report of the Aging Society in Japan. Japanese government releases annual report on the aging society each year, and this report clarifies the status of aging population, the implementation status of measures for an aging society taken by the government, and the measures to be taken in consideration of aging status in Japan. So I think this kind of issues discussed in Japan, it may be useful to you in Indonesia. So English version of this report is also available. If you are interested, please read further. I want to introduce one issues addressed in this report, regarding healthcare access and transportation in Japan. So there was a questionnaire conducted about the access to healthcare and transportation in 2018, and those Japanese male and female above 55 years old answered this questionnaire. So they asked the question, how often do you visit clinics or hospitals? And as you can see, this color, blue, green, dark blue, and brown, it's about 91.8% of the total. And blue is you visit the hospital about 2 or 3 times a month. And green one is about once a month. And dark blue one several times a year, and brown one not even not used. So Japan, although we have many elderlies, when we take a questionnaire to those above 55 years old, majority of them, 91%, says that they visit clinics or hospital only once or twice a month, or even less. And so all the rest of those who goes to clinics or hospital more frequently are smaller population. That's a good sign, because all people can live healthy without depending too much on healthcare. And this is another question in the survey asked about transportation and healthcare access. So they asked the same group, what are the means of transportation when using healthcare services? So this was counter to our expectations, but 50.9% of the who responded said that they drive their own car to go to hospitals. So about half of them. And then another about 20-30% walking and bicycling to hospitals. And transportation using public transportation is surprisingly not so high, 8.9%, this yellow one in the graph. And finally, transportation by family members and vehicles driven by neighbors or friends. These are very rare. So only 6.9%. So in case of Japan, I'm not sure about Indonesia, but when elderly go to hospital, they don't depend so much on others, but try to find a way to go to hospital by themselves, and majority of them drive by themselves. But this is becomes problematic when they become old enough, and when they are no longer be able to drive by themselves. So transportation issues in Japan in relation to healthcare access, the burden of the Japanese elderly of driving to clinics, hospitals, while worrying about one's own health. They always need to think about, what if I cannot drive anymore? I cannot go to hospital easily. And the burden of the family of the elderly, if the elderly can no longer visit to hospitals or clinic by driving by themselves, and need to ask the family members to pick up and drop off the hospitals. So in order to solve this issue in Japan now, new means to improve healthcare access through science and technology is already starting, and it's telemedicine. So telemedicine, the definition is medicine practiced with the assistance of telecommunication technology, often to provide care in remote locations or reduce the need for hospitals. And when we talk about telemedicine, there are 2 different types. So one type is inter-doctor model, so D2D. So these are the cases where a doctor receives advice online from another specialist doctor when treating a patient. So this is an example of Nagasaki prefecture. As you can see on this Japan map, Nagasaki prefecture is on the southern part of Japan, a small part, and this is an enlarged picture. But in this Nagasaki prefecture, there's a small, even smaller island, and Nagasaki Kyoto Central Hospital is located here. And so the doctors in Nagasaki Goto Central Hospital, they are supported by a specialist in Nagasaki University Hospital, who is located in the larger main Nagasaki prefecture. And the specialist is wearing this HoloLens, which allows a physician to see a 3D view of the patient. And he instructs the local patient, non-specialist doctor in remote place, this case in Goto Island, instruct how to treat the patients. So this is a doctor-to-doctor consultation, and it will enhance equalization of medical standards in Japan. So use of XR in the field of rheumatism and collagen disease, which are difficult to observe using just 2D, meaning like this kind of Zoom interaction coordination. But the patient who visited the Nagasaki Goto Central Hospitals on the remote island is connected with a rheumatology specialist in Nagasaki University Hospital. And the doctor is connected to a mixed reality system and 3D video camera, and MR head-mounted display are used to detect swollen joints in the hands and feet of a rheumatoid arthritis patients. So this patient does not have to fly over to the larger hospitals, but they can be treated locally with the help of telemedicine. This is one type. And another type is called doctor-patient model, D2P. And this is the cases where a doctor checks the condition of a patient at home or an elderly welfare facility through a computer screen and examines the patients. So telemedicine can replace hospital visit for follow-up purposes, such as checking prognosis after undergoing surgery at hospitals. So as you can see in this picture, the patient's home and clinic is connected by online diagnosis like Zoom or other means, and home visit medical treatment can be skipped if using online. So support for online medical treatment implementation is done in addition, and also telemedicine promotes network by visiting nursing daycare. Okay, and lastly, I want to introduce one example about the healthcare access for the minority in Japan. As Dr. Inge and I did the study together, I want to explain. So in Japan, 189,000 foreign Muslims are living in Japan as of December 2022. I don't know if you consider this a lot or small, but in total, it's only 0.15% of the total population in Japan. And I made this table of foreign Muslim living in Japan by country, and Indonesians are definitely the #1 group, 865 people Indonesians living in Japan, and followed by people from Bangladesh, Pakistan, Malaysia, and Turkey. And what all these Indonesian and others Muslims do, most of them are under specified skilled worker visa, which is granted to those who have a considerable degree of knowledge or experience to work in specific industrial fields such as nursing care, building, cleaning, industrial machinery, manufacturing industry, agricultural, construction, and others. So as you can see the picture here, I took it from this Japan Technical Intern Trainee Support Center Education Foundation website. But this picture shows how Indonesian nurses are helping the Japanese elderly, and some people also working in the factory, and also another one doing mechanical work. So all this, since Japan are lacking a younger labor force, we are now opening our door to foreign people who can come to Japan and work in such fields. And another important note is that Japanese native Muslims are very rare. It's difficult to find reliable statistics, but one source says about 2,000 of them only. And these are mainly those who get married to foreign Muslims in Japan. And so we did the study, qualitative research on healthcare access for the minority in Japan. The title of this paper is Factors Influencing Healthcare Seeking Behaviors Among Muslims from Southeast Asian Countries, Indonesia, Malaysia, living in Japan, an exploratory qualitative study. And in this case, we did a research qualitative study interviewing, but the research question was, what are the factors influencing the healthcare seeking behavior of foreign Muslims in Japan? So we did interview 45 Muslims, and we have come to 4 different themes. First theme is trying to comply with the recommendations of Islam. And theme 2, confusion about the healthcare system. Theme 3, improvising an informal support system. And lastly, language barrier problems. So I want to explain one by one in the next slide. The first theme of trying to comply with the recommendation of Islam is that as a Muslim living in Japan, there are all these restrictions that is also still remains the same when you visit hospital in Japan, especially for women keeping the aura, is having difficulty finding female doctors in Japan when receiving medical consultation. So one of the participants says, I called the clinic first, asking if there is a female doctor before making an appointment. And subcategory 2, permissible to receive healthcare. So each participant reflected on your own religious belief to determine when it can be considered darurat, the exigency situation. So it depends on the belief we hold as a Muslim, for example, about the medicine with ingredients from pigs. If there is no other alternative, I think I can't help but consume it for my own health and safety. For your information, in Japan, hospitals and clinics in Japan, most of the healthcare providers unfortunately have no idea about the concept of halal. So all the medication and other types of healthcare system is not programmed in such a way to care about the halalness of medicine or food. So even if you ask the Japanese doctors or nurses, they would have no idea. So that makes it difficult for Muslims to get to know the information. Subcategory 3, preference for halal food. Muslim patients, when they were hospitalized, preferred to eat halal food, but often found it difficult and had limited choices of things to eat. So this one participant talking about how it was difficult to communicate with the healthcare providers about their request for halal food. And subcategory 5, need for prayer space inside the hospitals. So as a prayer room is not available in Japanese hospitals, some foreign Muslims, when you have to visit the hospital for long hours during your prayer time, have some difficulty doing prayer. So this one participant says she was reprimanded by the security guard because she was praying silently in the hallway of a hospital outpatient ward. So that kind of thing might happen for you if you are living in Japan. And theme 2, confusion about the healthcare system. So this is another important aspect to be noted. When you experience healthcare in foreign country, you automatically compare with that of healthcare system of your home country. So and it's quite different depending on which country you are. So especially the participants have expectation and complain about the healthcare system at home is better. So this is a case for Malaysians, but in terms of cost, because when you go to a government clinic in Malaysia, it's free. But in Japan, even if you go to public hospitals, the medical fee is still costly, and also the same regardless of whether you go to private or public ones. So some of the Malaysians think that its medical care is expensive in Japan. And also operating hours, because in Japan, clinics generally open on business hours only from 9 to 5. But in Malaysia, the government clinic is open 24 hours a day. So some participants complain that what if you have an emergency situation at night, when how to visit clinics. And theme 3, improvising an informal support system. So this is an interesting behavior. We found that instead of talking to Japanese locals about which hospitals to go and what kind of healthcare to access, foreign Muslims are relying on information from other Muslim friends who are not so familiar with the Japanese healthcare system. So Muslim patients rely heavily on word-of-mouth information from peer Muslims when deciding which clinics or hospital they want to go. And another category, helping each other among Muslim friends. So those who are not good at speaking or understanding Japanese often visited clinics accompanied by not Japanese friends, but peer Muslim friends who are fluent in Japanese. And lastly, language barrier problems. This is may not be only for Muslim foreigners, but also other countries too. But in Japan, because it is difficult to communicate in English with the doctors and nurses, they have some difficulty. And Muslims in Japan prefer English communication for healthcare, but participants in this study and generally preferred English-speaking doctors and nurses, and you are trying to find clinics or hospital who can provide access in English. And also encounter problems due to language barriers. So some of the participants had difficulty explaining the needs for halal food during hospitalization because of the language problem. So this is the summary of my lecture today. In today's lecture, we learned a comparison of Japanese and Indonesian healthcare system, and we also covered a definition of healthcare access, and I introduced you the system thinking and causal loop diagrams, and I also introduced you some theories of related to healthcare access, social ecological model. And lastly, I introduced you some of the topics of healthcare access in Japan, the transportation issues, and also the minorities, foreign Muslims, healthcare access in Japan. These are the references if you want to read on more, and thank you so much. I think Dr. Inge is no longer here, so maybe Miss Aurelia, can you, how to do this from now?
Yes, Dr. Ayako, can you hear me? Am I audible?
Yes.
All right. Thank you so much for presentations from Dr. Ayako. And before we head into the questions and answer sessions, I have a message from Bu Inge that to read your curriculum first, because apparently Bu Inge misses to read your curriculum vitae. So if you let me, please let me share the screen first to read the curriculum vitae. All right, thank you so much. All right. Let me first read the curriculum vitae and resume of Dr. Ayako Kohno as our guest speaker today. Dr. Ayako Kohno is a graduate from the School of Medicine, the Public Health Program Specific Assistant Professor, with an academic degree from the Master of Regional Planning from Cornell University, Master of Public Health in Kyoto University, Master of Medical Science in University of Malaya, and PhD in Medicine in Kyoto University, with a research history from April 2020 present as the Graduate School of Medicine, Kyoto University, in the International Relations Promotion Office, School of Public Health Program Specific Assistant Professor. These are the teaching subjects that Dr. Ayako teaches. And Dr. Ayako has the research interest revolving a lot around global health and qualitative research in the research areas of life sciences, healthcare management, medical sociology, hygiene, and non-laboratory public health. That's how this is some papers that Dr. Ayako has published previously. And also the presentations, books, and other publications. All right, that will be the last thing that I will read for the curriculum vitae of Dr. Ayako Kohno. And I would like to thank Dr. Ayako for giving us such an insightful presentations for today. And I think we can begin to move on to the question and answer session. So if anyone here has anything to ask to Dr. Ayako Kohno, you may raise your hand.
Yeah, can you choose one of them, or how should I do this?
Oh yeah, I will help you choose to those who have raised their hand. For first, we have Shenli Devani from IKM 3B.
Okay, thank you. But first of all, sorry because I cannot on cam right now because due to my connection. So,
Okay.
Dr. Ayako, I would like to ask, is there any explanation why Japan has a massive number in amount of hospitals and clinics more than Indonesia, knowing the fact that Indonesia is bigger in population and region than Japan? And is each of those hospitals as busy as Indonesia, knowing the fact that there are many hospitals? And I often hear that Japanese are physically healthy. That's it. Thank you, Doctor.
Thank you very much. It's very interesting point you highlighted that yes, we have many clinics and hospital in Japan, and compared to Indonesia, so many. And why is it? There are, I'm sure, many reasons for it. And in my personal insights, as I explained in my lecture, privatization plays a big role, I think, because for the previous 30, 40 years, Japanese government decided that we would encourage private sector to take part in medical healthcare management. So now most of the percentage of private institution, medical institution, out of all clinics and hospitals are the majority. So that means that private clinic owners can compete. So especially talking about dentists, we are now have a kind of ironic way of saying that we have more dental clinics in Japan than convenience store. And in Japan, we have so many convenience store, but still the number of dental clinic is even more. So that means because healthcare is a profitable business, and if you make a distinction difference on quality of healthcare you provide, then it become popular in many patients, or for the standpoint of making profits, they are the customers. So they come to popular clinic. So that's, I think, one of the reasons that number of clinics and hospitals increasing. But also at the same time, even though you mentioned about the point of elderly and relatively healthy elderly, but definition of healthy is a bit difficult and misleading, I think, because when you come to a certain age, above like 60 or 70, even though you might not have a major problem in your daily life, like walking to somewhere by yourself, you will still have some kind of chronic symptoms like diabetes or high blood pressures, or these are, if you manage properly and not into a severe condition, still people can live relatively without minor problems. So, but you still need to visit clinics and hospital for your symptom management. So I think a lot of elderlies need to go to visit clinics and hospitals. That's why we have so many hospitals and clinics in Japan, I think. Okay, shall we move on to the next question?
All right. Thank you so much for the answer, Dr. Ayako. Seems like we have so many people raising their hands because they are very interested in asking regarding this topic. We will be moving on to the next questions. I think we have one question in the chat box from Sayaf Ibrahim Abiyu, but since he raised his hands as well, I will help in reading his questions. As what has been explained, the number of public health centers in Japan is less than in Indonesia. Does this affect promotive and preventive aspect in Japan healthcare system? And what is the prevalence of disease in Japan? Are there more communicable disease or non-communicable disease?
Thank you, thank you. So it's again similar to the previous question, right? The number of public, this time public health centers. Yeah. This one I wanted to highlight in my lecture. I don't know if you understood my message that, so we have many clinics and hospitals in Japan, but not many public health centers. And in Indonesia, as far as I studied, you have many puskesmas, the public health centers. And that's a very different structure. And so I would say that in Japan, in terms of healthcare promotion, we are in a stage that we no longer have to promote people to care for their health. Even though technically speaking in each different matters like diet or how do you say, smoking or walking, exercise, we still need a lot of improvement. It has to be done. But some level of awareness and knowledge is obtained in the general public that not so much great effort has to be put into promoting health to a degree that encourage people to come to hospital, but now is a matter of how to improve the quality of healthcare in the clinics and hospitals. So public health center plays a different role, I think, than what you do in Indonesia. This is my observation. And talking about the prevalence of disease, as we are aging society, many of the chronic and non-communicable symptoms, like I mentioned earlier, like high blood pressure or diabetes or cancer or this kind of illness is common, I think. Okay.
All right, thank you so much for the answers, Dr. Ayako. We will now begin to move on to the next questions, which will be coming from Farah Fadila from IKM 3A. You may have the floor.
Okay, thank you for the opportunity, Dr. Ayako and Aura. Okay, my name is Farah. I want to ask that, as I know, there's many elderly population in Japan that living alone. And as Dr. Ayako explained earlier, the Japanese government released an annual report on the aging society and the implementation status of measures for an aging society taken by the government. And as mentioned by Dr. Ayako too, there's factors affecting health at society level that if some elderly living alone may lead to feeling of loneliness and depression. Then does the elderly population that living alone in Japan is experience loneliness and depression too? And how does the Japanese government especially address and handle the elderly population? Are there any special ways for health workers to prevent elderly depression? I think that's my question.
Thank you very much. It's a very important issue now in Japan. And so how to improve and solve this problem is not so easy. And so as I mentioned, the society-wise, we are moving on to a perception that living alone itself is not always directly linking to loneliness and social isolation, because you could, as an older person, you could still live alone and be able to access to the community if you join a community held like exercise group, or going to a local gym, or take some kind of cultural lessons and interact with the people at the same age or other generations. But those who have a sign of loneliness or symptoms like other mental illnesses, it has to be identified. So early identification of all this potentially high risk group is a challenging issue for Japanese community now, I think, which is have been conducted in some local governments when there is a social gathering activity. They try to identify those kind of groups, but I would say it's quite difficult to implement the same kind of activity in all parts of Japan. So at the local government level, some unique activity has been conducted. And also because this topic is still under investigated, I feel like there is much study is needed in the near future.
Thank you, Dr.
All right, thank you so much for the answers. Now we will begin to move on to the next questions, which will be coming from Azra Raisha.
Okay, am I audible?
Yes.
Okay, 2 weeks ago, Mrs. Inga told us about her experience in accessing healthcare in Australia. As much as I remember, she told us that she has to wait for several months before her child is able to do surgery. While in Indonesia, we don't have to wait for surgery, and the surgery can be done as soon as possible. Then my question is, does Japan apply the same system as Australia? Do we have to wait for surgery, or is it as easy as in Indonesia in terms of receiving advanced medical treatment such as surgery? Thank you.
Thank you very much. It's very interesting question, and because I don't know so much about the Australian medical system, but I'm assuming it's similar to UK system, which is you need to first access to GP in your local community, and if you go through the public funding system, you have to sometimes wait for a long time for receiving surgery. But in Japan, it's not the case. As I explained in my lecture, people can go to any hospital or clinic of your choice. You don't have to go to the nearest one where you live. And you can either go to public or private hospital. And supposedly the quality of medical care is not so different either way if you go to public one or private one. But the issue is maybe what you seek for. If you want to go to high quality doctor who is very famous and have talented skills to do successful rate of curing for cancer, for example, then you might have to wait for a long time because this popular doctor has a long waiting list. But otherwise, if you don't have that strong preference, then if you go to any of the hospitals in Japan, but you may still have to wait in terms of scheduling. But I wouldn't say 2 or 3 months. It should be done in a reasonable time.
Okay, thank you so much for the answer.
Thank you so much, Dr. Ayako, and thank you so much also, Raisha, for the questions. Now we will move on to the questions which will be asked by Gemma Kailia. So you may have the floor to ask your questions.
Okay, thank you. My question about this presentation, you mentioned telemedicine. And telemedicine is a sort of, from what I understand, is sort of like an online treatment for people, especially elderly people who cannot access healthcare offline or, going to a hospital. And what I want to ask is, does telemedicine can replace the connection or, the emotional connection that usually happens when we actually go to the hospital and actually consultates with the doctor? Because I know that this is actually very helpful for people who cannot go to the hospital, but can this help them, especially for elderly or people who are, with disabilities, help them emotionally and also psychologically in that sense? So.
Thank you very much for important question. I agree with you that because healthcare is not only about technology or the quality, but the human interconnections. Nothing can replace the online diagnosis, which is you cannot face a patient directly. But as I explained to you in my lecture, there are two types: doctor-to-doctor telemedicine, which is only communicating between the doctors, and the local doctor can still interact with the local patient. And even with the case of doctor-to-patient category, as I explained in my slide, it's supplementing the regular home visit or the clinic visit, but it's not entirely replacing. So I think how to use it effectively is we need to choose, but the optimal way is maybe to combine telemedicine with the regular diagnosis, which is done face-to-face.
All right, thank you so much for the answers, Dr. Ayako. Now we will begin to the questions from Kalista Naura.
Okay, doctor. I have mentioned from your slide about the National Insurance Health. They are enrolled for self-employed, freelance, and student. And I want to know about how they, the system, I mean the system insurance, so they can apply to if they go to like hospital or primary health access. So because I have insurance too in Indonesia, that if I apply to cover my healthcare, I actually just pay like just 10% from all the payment like that. Maybe I want to know the system like that, doctor. Thank you.
Thank you very much. So how the system of insurance work in Japan is maybe similar to Indonesia, I think, because if you are subscribed to one type of insurance, you need to pay the monthly premium fee, which is depending on what type of insurance you subscribe to. If you are working for a government or a private company, the healthcare cost premium is deducted from your salary monthly. And in case of your self-employee, you need to pay to the local municipal government. So that's like a minimum monthly premium you need to pay. And then when you actually go to hospital for receiving some kind of medical treatment, that after the end of medical treatment, after you receive consultation from the physician, before you go back, you go to the counter in the hospital and they give you the like a receipt, like how much is your medical fee, which is automatically calculated based on what category you are in. Most of the population is 30% of the actual cost you have to pay. So that you just pay and then go home. That's how it works.
Okay, thank you, doctor.
All right, thank you so much for the answers, doctor. Now we will begin to heard the questions from Alvina Arista.
Oke. Sebelumnya mau nanya Mbak Aurel, suara saya masuk ya?
Yeah, yes, you're audible.
Oke, thank you.
I think I cannot hear her anymore.
All right. I think she's having some technical issues. Lina, can you repeat the questions?
Maybe I with the question.
Now I can hear. But,
All right. Maybe to to help her, because I think she's having some technical issues, I will help reading out the questions from the chat box. The questions is how to overcome health problems in aspects of economic governance and health aspects in Japan. Because in Indonesia itself, this issue is still often discussed and is a problem of inequality.
Thank you, thank you. Yes, it's an important and difficult question, but it depends on what kind of healthcare provision you are in mind. In Japan, there are so many different ways to support the people of low income people. I didn't mention too much in this lecture because lack of time, but if you, for example, if your monthly medical expense exceeds certain amount, like in the US dollar was maybe $500 or above, because you have had to go to hospital so much because of receiving surgeries or taking expensive medication and so forth, then you'll be reimbursed later. It's not immediately, but after 1 or 2 months, the local government calculates how much expense you have paid, and you will be reimbursed. So this is a system to try to support the all citizens. Try not to go bankrupt by paying medical fees too much out of your total salary. So this is one social healthcare like a safety net system that is in place in Japan. And also for another like very low income group, there are other means to so that people are exempt from paying any medical fees. But this one, there's a bit of paperwork you have to do to be able to prove that you are have very low income and so forth. So there is a support from local government, like public health centers, needed. But there is a way to help all these people who are in a low socioeconomic status.
All right, thank you so much, Dr. The answers to Alvina's questions. We will now begin to hear from Aisha Devani because she's raising her hand. So Aisha Devani, you may have the floor.
Okay, thank you for the opportunity. Am I audible?
Yes.
Yes.
Okay. Based on Dr. Ayako's explanation and the presentation of the previous slides, healthcare and clinics in Japan are dominated by the private sector. And I just thought that the cost will be more expensive, right? And my question is how to manage the insurance for the healthcare from the government, considering that the demographics of the population in Japan are many people of elderly people that may be not working anymore, and maybe for people with low incomes.
Thank you
So,
for
okay, thank you.
Okay. I think one thing I need to clarify is that I don't know so much the case in Indonesia about the price difference when you go to government clinic and private clinics. But in Japan, as I informed in my lecture, regardless of whether you go to public or private clinics, the medical fee is not so much difference. That might be surprising to some of you who have not experienced, but because we have a regulation in Japan that clinics, regardless of government or clinic, can charge people depending on the type of symptoms or the type of medical services that the clinic or hospital provide. So this is one thing that is maintained, so that even though if you go to private clinics, the medical fee is not so surprisingly more than compared to when you go to government clinics. But of course, there are so-called out of medical, how do you say, system healthcare services. That's difficult to explain, but when you opt for like cosmetic surgeries or even cancer treatment, if you choose to receive a treatment that is not in the package of what the Japanese government designate as one of the standardized medical treatment procedure, then you need to pay 100% of that medical cost. So that, of course, adds to the cost of medical fee. So, but what I want to say is that because Japanese healthcare system is designed in such a way that it doesn't make people in difficult situation if you seek for healthcare. Basic fee for medical cost is maintained in a relatively lower price. It's controlled. I hope I answered your question.
All right. Thank you so much, Dr. Ayako, for the answers. I think we still have around 10 minutes left. So if anyone wants to ask more questions, I highly encourage all of you because as participants, you're encouraged to ask questions, to share your thoughts, and to present any relevant examples. As this is meant to be an interactive discussion between us and Dr. Ayako, so don't hesitate to contribute our insights here. All right, I will be counting down. 3, 2, 1. All right. That means the questions from Aisha Devani was probably the last questions for our sessions today. Before that, I would like to say a massive thank you to Dr. Ayako for giving us such an insightful presentations regarding to the healthcare access in Japan. As these sessions from the beginning, it has been promising to be an enlightening explorations of the Japanese healthcare system itself to unveil both of the theoretical underpinnings and contemporary issues that shape access to healthcare services in Japan. All right. I think it's since that we don't have any other questions here, we can begin the documentation sessions. So to everyone, please open up your cameras. I will begin to documentate in 3, 2, 1. All right, for the second slide, 3, 2, 1. The third slide in 3, 2, 1. Still have 2 slides left for the fourth slide in 3, 2, 1. The fifth slide in 3, 2, 1. And the last slide. Since no one is opening their cameras on the last slide, I think that will be the last slide to document. Before we wrap up the sessions, I would like to say once again, thank you to Dr. Ayako for giving us such an insightful experience and insightful presentation so that we can identify the healthcare access in Japan, and as a public health students to identify the differences between the healthcare access in Japan and Indonesia. And as well, we've learned some study cases today regarding Muslims as the minority in Japan and how the healthcare access disparities, how can we overcome them in Japan. And we can also ask our questions and to receive more information regarding the topics today. So thank you so much, Dr. Ayako, for giving us your times. And thank you so much for everyone attending today. Thank you so much for everyone who has been asking their questions. You're also giving an insightful presentations and experiences to all of us today. So yeah, that will be the last sessions for today. Thank you so much, Dr. Ayako.
Thank you so much. I really enjoy discussing with you all, and wish you all the best, and hope you have a chance to visit Japan sometime.
All right. Thank you so much, Dr. Ayako. All right, since we've finished with our guest lecture today, you may leave the Zoom meetings. And thank you everyone for attending today.